Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening all to our meeting, Emirate Cardiac Society series webinar. And tonight is a very special one. I think is interest to every physicians, nurses, anyone in the field of medicine and patients and the relatives. So I think we have a great audience already registered around 500 for this meeting. And I'd love to see your comments and questions. And for this meeting, we have highly caliber, 2 speakers from different big institutions in the country. Today is about smoking cessation, reality, evidence. If you look at the data worldwide, looking at the cessation and what's happening in the people dying from smoking for the last century, around 100 million people died from this. The good news is that there is a reduction or there is a cessation happening in the smoking, which is due to many things. And this is going to be discussed by our expert tonight. But still there are, many work to do because our young, is the problem. We are talking about 2050, our who are born now is going to lead. So for them to be protected. And we have as I said, our expert here to discuss this and to bring this to the surface. I'd like to hear your comments and evidence. Our meta-analysis showed that the prevalence in Middle East of smoking is around 16%. And that, of course, varies from country to country, but an average. So if you look at the reason of people dying from cardiovascular disease, the first one is hypertension, second one is smoking. And that tells you that by every year, almost like 8 million, up to 9 million dying from smoking, compared to COVID, which is less than 1 million. So too much media on COVID, forgetting about the smoking. Today we bring the focus on the smoking. The WHO target 2025 to reduce tobacco smoking by 30%. How to do that? Is through effective tobacco control and affordable way of doing that. So for that, I have 2 speakers, Dr. Sharif Bakir, colleague and friends, long time, an expert in the field of tobacco, but he's cardiologist in training. He's been in different places in UAE, and now he's in Shakhbout Hospital in Abu Dhabi. And he actually runs the Center for Smoking Cessation and wide experience in the field. And he can share with us tonight, his why people smokes. Then we have Dr. Iyad Hassan, staff from medicine from Cleveland, Abu Dhabi. Used to be in Cleveland, US, now Cleveland, Abu Dhabi. Loves Cleveland, so that's why he's here. An expert in the field of tobacco for long time, maybe 17 years, 16 years. So he will share with us also the therapies, what's available, how to manage smoking and cessation in a practical way. So we're going to start with Dr. Sharif Bakir. Dr. Sharif, we're looking forward to your talk and your presentation.
Thank you very much, Dr. Abdullah. I am now sharing the screen. So let us to open the screen. I hope you can see my screen. You can see it now? Okay. It's a great honor and a pleasure for me to be with you today. And all the time we said, you have to know your enemy. If you want to understand how to stop smoking, first you have to know your enemy. I changed the title of my talk. I said, Smoking, the Untold Love Story. What does it mean? Why we said this? Simply because the truth about smoking, you have to understand that nicotine addiction. When you smoke, smoking is associated with pleasure and feeling of happiness. This is number 1. Number 2, cigarette can make you relax. Number 3, you might even think of cigarette as a close friend or the second wife if you want. Why this? This is very important to understand this, and then you will understand how to stop smoking. So most of the smokers, they said, I love smoke. Yes, true, because it's a friend. They talk every day with the smoke, with the cigarette, but in the same time, they don't know that cigarette is the one going to kill them. So let us to understand what is the problem in smoking. The problem of smoking is 2 things, habit and addiction. Habit and addiction. And I will ask any of you, which one you think it will be difficult to be treated with or to treat it first, the habit or the addiction? In my clinic, when I see the smoker, I told them which one. 95% of them, they said the problem is addiction. While the truth is the problem is in the habit. Addiction is very easy to control. And this is well known, and I will explain to you why. First, we have to understand how smoking gives you the pleasure, and then how the smoke can let your habit be difficult to be treated. This picture is 1955. They said a man buying cigarette in a hospital because they find that the patient, when they admitted to the hospital, the first thing they ask about was their cigarette. And this was they are the nurse selling the cigarette for the patient in the hospital. So to understand the problem, let us to go to the mechanism of smoking. What will happen? When you start to smoke your cigarette, after 5 to 11 seconds, the nicotine reaches the brain. And once it reaches the brain, within less than 5 seconds, the brain will secrete the dopamine. Dopamine is the secret of happiness. Dopamine is the secret of happiness. You will feel happy, you will feel enjoy, you can concentrate, you can do whatever you want, you can be calm. This is because your brain secretes the dopamine. The question is, what about the non-smoker? What the brain secrete? I mean, if I smoke, I get the dopamine. So the people who are not smoke, from where they get their dopamine? To understand this, we have to know that once you smoke, the dopamine will secrete it from the receptor to go to the brain, and then you will feel the happiness and everything. There is something called the automatic and the manual theory. What is the automatic and the manual theory? To understand this, as we said, the nicotine, the addict, this is the brain, this one, the brain of the smoker, and this is the brain of non-smoker. And I will show you in the next few slides what does it mean. Nicotine addiction, when the smoker awake in the morning, he needs the nicotine. He needs the nicotine for why? Because he needs the dopamine. But what about the non-smoker? From where they get the dopamine? I will explain to you. But I want you to look to this picture and to concentrate on it, because we will return back to this picture again. As we said, this is the brain of the smoker, and this is the brain of the non-smoker. What does it mean? If you look to the brain of non-smoker, this was the green color, while the brain of the smoker was the blue color. The blue color, this is called the nicotine receptor. The smoker creates in his brain something called nicotine receptor. The problem, we cannot able to take this nicotine receptor out of your brain, but we are able to let it sleep. To understand, this is the mechanism. I will not go into this detail, but just to show you that you have the nicotine receptor in your brain. And what will happen if someone stops smoking for 48 hours, the nicotine receptor will be blocked, sleep. But if he starts to smoke again, even after 10 years, the nicotine receptor will be awake again. And this is why most of the smokers tell you, doctor, I stopped, I smoke, I stopped and retain. This is to understand this because of the nicotine receptor theory, which means that you are able to block the nicotine receptor. And this is the addiction. And by the way, the smoking also have, when you smoke, they have effect on the depression. It has been found that the people who are non-smoker, compared to the brain of the people who smoker, there is the monoamine oxidase, and this also related to the depression. And we find that there is a difference between the smoker and non-smoker. So what will happen? This is applied to any addiction. If somebody addicted to alcohol, heroin, cocaine, anything, all of them will act through the same mechanism, which is the dopamine release. So now I return back to the theory, which is the automatic or the manual. To understand this in a simple way, if you have an AC in your house, the AC can be act as automatic, which means when the temperature in the room is hot, the AC will start to act or to work. Once the temperature cool, the AC will stop. This is your brain. This is your normal brain. So when you awake in the morning, you need the dopamine. Your normal brain gives you the dopamine. After 15 hours, after 15 minutes, half an hour, whatever, the dopamine level decrease, your brain will give you again. When you are anxious, it gives you dopamine. When you want to relax, it gives you dopamine. When you want to be happy, it gives you dopamine. While the smoker, the dopamine release from the brain, it will be like the manual, which means that you have to stimulate your brain by the cigarette. So this is called the manual or the automatic theory. Our aim in the nicotine cessation clinic to retain the brain of the smoker to the automatic way, which means that we want not depending on the nicotine which is coming from outside. I want my dopamine to be released automatically. The problem also for the smoker that when you awake in the morning, you will find that about 70 to 80% of the smoker, when you ask them, you take your first cigarette before breakfast or after breakfast, most of them you say, doctor, I am awake in the morning and take my cigarette. Why? Because he wants to stimulate the brain to secrete the dopamine. So this is the problem that you are, when you take the first cigarette, I will tell you this number, which is imaginary number, is not the true number. But for example, if you take the first cigarette, your brain, for example, will give you 1 gram of dopamine, for example. Then after 10 minutes, 15 minutes, whatever the time, the level of the dopamine in your brain dropped. So you need another dopamine. So what you will have, you will take another cigarette. This is lead to what? The second cigarette will give you amount of release of dopamine less than the first cigarette. You will find yourself or the smoker, he needs 2 cigarettes to get the same effect which he get from the first cigarette. So what will happen? He will start by 1 cigarette in the morning, ending by 40, 60, 80, whatever in the night. And this is what we call the nicotine addiction and the need for to release the dopamine. This can be controlled, the addiction can be controlled very simply by stopping smoking for 48 hours. But sometimes he said, doctor, I cannot stop for 48 hours. What we'll do here, we have, and Dr. Ayad will talk about, we have the nicotine receptor and the nicotine patch or nicotine replacement serum. And by the way, this is applied to the cocaine, heroin, anybody addict, any patient addict to anything, he entered the hospital for 2 to 3 days to be repeated from the addiction, and then he will be released from the hospital. And 6 months later, he will come back, not by the addiction, he will come back by the habit, which is very difficult to treat. And this is the problem. We need to how to treat. So this is why we are dealing with the patient by treating the addiction very simply by replacement therapy, but the habit, this is the main problem. And I will not talk about the treatment because Dr. Ayad will cover the treatment, but the habit is the main problem. And we use many ways by the psychotherapy, which is not my topic today, how to treat the habit. Then I want you to understand something very important also. There is some people, they have what is called genetic addiction, especially female. Some human female chromosome, they sometimes have addiction to alcohol and nicotine. So sometimes it will be difficult to treat this type of people because they have genetical relation to addiction. But most of the patients just will ask them very simple question. Did you stop before? He said, yes, doctor, I stopped for 1 month or 2 months. This is give me release. I know that he's not the type that they have some form of genetic. And this is very simply to let you to start to deal with the patient. So as I said, I want to give you some statistics. You have to understand that tobacco affinity or the probability to depend or to be addict to tobacco is 32 times more than heroin. And if they found that if someone take the first cigarette in his life, his first cigarette, about 32% will be addict immediately. While in heroin, it is 23%. So the addiction to cigarette is very, very strong. Another important statistic I want to know. This is in Ottawa model in Canada. They have done this. They found that most of the patients admitted to the hospital for whatever, any reason, 20% of them, they are a smoker. When they look to addict center, they find that it is unlikely to find somebody addict to alcohol or cocaine or anything without being addict to smoke. So first they start the addiction of smoking and then go to other type of addiction. And also they found this is in the people with mental illness. So it is very important to understand how this affects that smoking. It's very difficult to get rid of it. Also, this paper have been published in 2013. They found that the smoker lose at least 1 decade of their life expectancy. This is very important. It is a very dangerous thing. And World Annual Tobacco Deaths, they found that developed countries, 2 million, like in China, 1 million died from smoking, and in India, 1 million. Worldwide, 5 to 6 million, but this is rising up to 10 millions. And they found that, according to WHO, the calculation, they find in 2000, from 2000 to 2019, about 100 million. I mean, from 2019 to 2020 to 49, about 250 million. As Dr. Abdullah was telling, everybody was talking about COVID. How many people died from COVID? But look how many people died from smoke. If you remember a few years ago, SARS would put cameras in all the airport. How many people died from SARS? Nothing compared to the people died from smoke. Another important statistics, which is very important. If you talk to anybody will find about 60% of the smoker, they want to quit. They said, doctor, I want to quit, but they are not able to quit. About 50% of them attempt to quit. The other 50, they didn't attempt, not because they don't want to quit, but they know that they will fail because they are afraid from failing. But if you find somebody success to quit alone without support, it is minority. 4 to 7% of the population of the smoker, they are able to quit alone. So this is why they need the help from the smoking cessation clinic. And in the smoking cessation clinic, we usually deal with addiction. This is very simple to be controlled by nicotine patch replacement therapy. But the problem will be in the habit. And as I said, for example, in Canada, the smoking, Dr. Abdullah Shahab give us the statistics in Middle East. It is very high, and especially we don't know in female, because many of the females in the Middle East, they didn't say that they are a smoker. And now we have to know the shisha. Shisha, it's very common now. So smoking also is the leading cause of hospitalization. They found that most of the people hospitalized to hospital are related to, this is in the European Society of Cardiology meeting 2019. The readiness of quit, as I said, you can hardly to ask anybody smoker, do you want to quit? He said yes. All of them, they said yes, but they are not able to do because they feel that they cannot do it. And when somebody came to my clinic, they said, doctor, I'm smoking since 30 years. I told them, no problem. We can stop it. Addiction, forget about it. The problem in the habit. And I will give you a very small clue about how we can control the habit. This is because this is not my topic today, but we will use what is called the theory of thief. What is the theory of thief? Theory of thief, this that we want the patient to give them the replacement therapy, but in the same time during the psychotherapy with them, we'll try to let them, when they thought about smoking, we try to deviate their attention. I tell somebody who start to smoke, I will ask him a very simple question. If you have a brother that's not married before, and the brother came to you with a very nice lady, very beautiful lady, he will tell you, I want to marry her. What you will tell him? Oh, go to marry her, she is very beautiful. But your mother said, no, let us to ask about her. So when you ask about her, you find that it's not good for your brother. So what you will tell him? You will tell him, my brother, I love you. Please don't marry this lady. He will tell you what, can I speak to her every day at night to listen to her voice or to hear her voice? Can I see her while she is going out from her work? What you will tell him? My brother, you will never able to forget this beautiful lady because you are seeing her every day. The same for the smoker. When we give him nicotine patch, I told them, don't put the nicotine patch or don't start whatever, any type of treatment. And you are keeping the cigarette in your pack, in your home, in your car, in your clothes, in your office. You will never stop smoking because you are seeing this every day. But if you are able to stop as a replacement therapy and just to start to smoke, to think about the smoking, deviate your mind. I give you, Dr. Shahab, how many minutes we left? We still have?
10 minutes.
10 minutes, oh, still very good. This is the new guideline 2019 about primary prevention. You will find the smoking is the most important part. I will return back to what I called about the habit. Any of you, I think most of us have been bitten by mosquito or ants. Yes, what will happen? When you bite by mosquito, there is a swelling, small swelling, and then you feel itchy, and you start to itch. Do you know the mechanism of itching? Why when you became, bitten by this type of mosquito and you start to itch? Now you are sieving or deviating your brain from the bite, because once you have been bitten by mosquito or by whatever, histamine released from this, and this is irritates your brain. So once you start to scratch your skin, you deviate your brain from the thinking about this histamine and this mosquito bite for a few seconds, and the brain will forget about this, and after half an hour remind you again. The same story when we tell the people who are smoker, we told them, now we give you the replacement therapy, but now or whatever therapy you are taking. Now when you don't put the cigarette in front of you, don't put it in your pocket, don't put it in your house. And once you awake in the morning and you start your think about smoking, deviate your attention. It is very simple. If I am talking to you now and my telephone ring, when I answer, when I return back, I cannot, impossible to remember what was my last word, because my brain have been deviated. This is what we are trying to do with the smoker, to deviate their attention. I will give you a final example and then I will stop my talk, which is very simple. If your child or your kid, 4 years of age, and he is playing in his nose, if he went to the school while he's playing in his nose, all the kids around him will laugh on him. So how we can let him to stop playing in his nose by his finger? Very simply, by deviate his attention. If you punish him, he will never stop. But if you deviate his attention, he will stop. This is what we are trying to do with the smoker. We give him the replacement therapy, we give him whatever type of medication we are, and then for the habit, they deviate his brain or his attention about the smoking by doing something else for 5-10 seconds. He will forget the cigarette and then will return back again. Also, don't forget about the people around the smoker. I like this picture. It said smoking section, and this is second-hand smoking section. So we have to know that it's very difficult to be away. This is not a beautiful lady, but acceptable. But actually, this is her face. This is what she has, cancer everywhere. You have to remember this. So I hope by this you understand the mechanism of smoking, and by this way you are able to help your patient to stop. Don't forget to show him this, the benefit of quit smoking. Maybe Dr. Ayad will touch these things, but it's very simply that once you stop smoking, the carbon monoxide will decrease within 12 hours. After 2 to 3 weeks or up to 3 months, the heart attack and the lung problem reduce, and all this you will gain by stop smoking. So finally, as I said, the pharmacological therapy, either replacement, psychotherapies, or the new medication, Champix or the varenicline. Don't forget that we have many types of replacement, and this is how the varenicline will act. I think Dr. Ayad will touch this. And Dr. Abdullah Shahab raised a question about the e-cigarette, but I think e-cigarette need another session. So I hope that you understand what I'm trying to say. It is untold story of love story, because the smoker loves the cigarette, and we have to divorce him from this cigarette. Thank you very much.
Excellent, outstanding as usual, Dr. Sharif. You took us through a nice, great journey. Why people smokes, the reason, and how to with the final time of how to manage this. I think it's the right time now to move to Dr. Iyad. So
let me go out from the sharing.
So we're going to learn now after this great journey with Dr. Sharif is to look at what's available, what's effective, because what WHO says, we want to reduce this, but with something affordable. So we'll see Dr. Iyad take us through this, inshallah. And we have already 253 active participants with us. Please write your questions, comments, so we can discuss it then. Dr. Iyad, the floor is yours, please.
Thank you for having me today. And Emirates Cardiology, do you guys see my slides in front of you?
Yes.
You do, great. So my name is Dr. Iyad Hassan. I've been in tobacco cessation for, as Dr. Abdullah has said, for many years. I originate from the Cleveland Clinic. If you don't know about the Cleveland Clinic and our stance on tobacco, we take a very hard stance in the United States. We hope the Emirates becomes like this. In the United States, if you are a tobacco user or you test positive for nicotine, your job is rescinded at our hospital. We really strive very hard to focus on it. We had a great CEO. As we continue now with our CEO, tobacco is a big passion of ours. Because of the Emirates Cardiology Society, I focused on the cardio safety of many of the medications. I am going to go over the medications on a high level, but I also want to touch on a recent study that came out called the CAT study off of another past study that was there in the past that actually demonstrated about the tobacco cessation. So let's first start this. I show this slide to all my cardiologists out there. And please take a little chance to look at your slides that you have in front of you. Standard treatments to reduce the risk of death in any cardiovascular patients, 15 to 35. Aspirin, statins, beta blockers, etc. As you can see, the numbers are in front of you. But if you look, tobacco cessation can reduce the risks of individuals with cardiovascular disease by 36%, and if not more. The problem is I talk to all my colleagues who are physicians and nurses and pharmacists out there, is tobacco cessation is not the sexiest of all the treatments out there. We focus on wanting to open up the hearts. Let's do a TAVR. Let's do this. Let's do that. But we fail to focus on the preventative aspects of it. Now, if we take Dr. Sharif's aspect of behavioral therapy and we put in medications, this is a quick summary of it. If you look at it, if you add support plus medications, you, if not, triple the chances of an individual able to quit smoking. So having support and some type of pharmacological intervention is key to the success of a person quitting. Now, Dr. Sharif gave you a great aspect. He even ran it down to the aspects to showing you the importance of how the body even changes originally. So I'm going to continue to focus a little bit on the behavioral side, but I really want to focus on the medications. If we go to first-line agents, we've had agents all the way back since 1984. We have gums, we have patches, we have nasal sprays, we have inhalers. We had bupropion, then we had the lozenge, and then bring in varenicline. Now, all these medications have their pluses and have their minuses. We could go in and we can break down each one. Real quick, nicotinic replacement, or NRT, as many people, whether it's the gum, the patch, nasal spray, goes in and it actually goes to the nicotinic receptor. Bupropion, we still kind of do not know the actual true mechanism of the medication itself, but we know that it does help with the release of dopamine. The true story behind bupropion is interesting because it was meant for depressed patients, but the depressed patients were saying, hey, I'm also quitting smoking. So it was one of those interesting aspects that the company finally, GlaxoSmithKline, said, I think we could take this drug and actually try to help the world. Sadly, a lot of the insurances still don't cover it because of the actual psychological aspect. And then you have varenicline. Varenicline hits the nicotinic receptors on the alpha and the beta aspects of it. It actually is, in many respects, a blocker, but it also helps release a steady release of the dopamine. Now, with that high release of dopamine throughout the day, the individual, as you saw from Dr. Sharif's graph he has, is able to help cover that desire for the physical drive of it. As Dr. Sharif said, there's a lot of behavioral sides to it that you have to do. But with every medication, it has its pluses and it has its negatives. And in this, as you can see in this graph here, I kind of laid you out the most common things I see in many of my patients and that have been reported in the literature. Sadly, bupropion and varenicline, on top of nicotine, which is an actual stimulant itself, have cardiac involvement. So many people may report tachycardia or feelings of chest pain sometimes with it. People have always asked me, do you use nicotine replacement immediately after an individual with an MI? Once they're stabilized, we really try very hard to control their nicotine withdrawal. But the main aspect with many of these agents, especially the psychological and the actual nicotine receptor agonists, is that they came up with psychological issues that much of the media grabbed on and started to push out that is it better to actually smoke than to actually feel that you have mood changes, feelings changes, even possible homicidal, suicidal changes and beliefs. So we in the tobacco world went very hard. We drove a lot of the governments, whether in the US, the UK, all over the world, to try to take a stance that we want to beat this. We need to beat this. We need to take a bigger stance on this. So what they started doing is, especially, and again, I focused on cardiovascular, they started throughout the whole time looking at patients and trying to decide, okay, what works for these patients? I've listed 3 famous studies in themselves that are pretty straightforward, Dr. Aziz, Rigonati, and Barth. Each one started talking about behavioral changes that you could do. Aziz actually will tell you, and much of the data actually relates to this, your chances of success are better if you increase the number of interactions with an individual. On top of it, the longer, the more intense you can grab that individual, you can actually really focus on that person's behavioral change even better. And then, of course, in the first study, they talked about using nicotine replacement bupropion. On top of it, if you look at Rigonati, he actually looked at it in a different way. He actually put counseling and follow-up with all these patients, even 1 month after. With that being said, as you can see, they had a great response rate with it. And all they used was nicotine. But the big one, Barth, in 2015, actually did show any type of intervention you try to provide for this patient, self-help, telephone, etc., betters your patient's chances of success. So my friends, there's a lot of research that are out there that tells you try to do anything. I ask you for one thing. Although it doesn't come out here so much because it really focuses on the intense intervention and everything, research shows that if you can give 60 seconds of your time. Now look, in medicine, we don't have time. We need to turn the room over. We need to push these patients out the room as fast to move the next one. But if you have a patient who's a smoker, I ask you to intervene for 60 seconds. And I'm not telling you to push them, especially if they're a total pre-contemplator or a contemplator to the point that they don't want to quit right now. Just asking them, whenever you're ready, I can help. That is the message that we push all the time. When you are ready, I can help. And here's how I can help you. I can offer you behavioral changes, but on top of it, I can offer you a way to help control this addiction. Now, if we look at tobacco safety and medications, as we said, a lot of the world became very scared of nicotine replacement because of cardiac issues, bupropion because of cardiac issues and psychological issues, and varenicline. Sadly, first because of the actual psychological issues, and then became part of cardiac. But as you can see from the studies I've listed for you right there, studies over and over and over and over have said that, look, these 3 medications are safe to use with patients with cardiovascular disease. Do not be scared. Definitely try to use them in any way to help this person quit. Now, what then came out was the fact that all our passion, all our push actually finally got motion through the US FDA and through the EMA to finally push the manufacturers of these medications, especially varenicline and bupropion, to say, listen, first things first, we're getting a lot of scares or adverse events that may be related to psychiatric or neuropsychiatric issues because of your drugs. We want you to compare these studies. In the previous slide, they just used those simple medications. They didn't compare it. The Eagle study went full board. They did multiple sites for a long time, and they actually decided to say, let's answer the question of all questions. Do all these medications going head to head, okay, going head to head, actually make these individuals have psychiatric issues? On top of it, they also decided to say, let's look at an extension of it, and let's look at the cardiovascular risk. So the Eagle study, as you can see straightforward, I don't want to read, I'd rather talk to you, actually took the medications of varenicline at 1 milligram BID, bupropion 150 BID, and nicotine patch 21 with the taper, and compared it to placebo. This study was amazing because we had multi-international sites, and we looked at each person's actual risks for psychiatric and non-psychiatric issues. On top of it, we also looked at the cardiovascular risk. Because remember what I said in the beginning of the study, literally, we were worried. We were worried of the fact of neuropsychiatric and cardiovascular. Now, what Eagle came out and said is in the end of its study, and I believe the next slide shows the diagram of it, we're going to take these people through basic treatment. We're going to follow them after treatment, but then we're going to do an extension of it. And we're going to find out really what are the side effects that we have to worry about psychiatrically and cardiovascularly. Psychiatrically, it was a no-brainer. It was an overwhelming study that showed that please do not hesitate to use it with individuals who are depressed, anxious, individuals who have schizophrenia. It's to the comfort of the clinician. And there's a principle which before you leave, I really want you to focus on that should be the driver that tells you how to literally treat this disease. In the end, after following through this, they did an extension and then looked at the cardiovascular risk. The rest of the data that I'm going to show you is literally a breakdown of this. Now, they broke it down to what they call MACEs or MACEs. Although it's not showing to you, if you had a MACE of 1 or more, which is cardiovascular death, non-fatal MI, or you had a stroke, they called it just a MACE. A MACE plus was any of those 6 items that you saw there. The idea was, let's see what happens if we follow these individuals while they're on treatment, when they're on non-treatment, and extension right after. As the Eagle study demonstrated, there is a lot of people were in the study, and we had over 2,000 in each group. And as you can see, at least 1,500 completed it. The extension even had almost 1,100. This is amazing response and numbers for this type of study. Now, if we look at the actual patient safety of it, the individuals were mostly in their 40s, mostly males, white at the time, and they had a little bit higher BMI. And as you can see, the psychiatric cohorts as they are non-psychiatric and psychiatric themselves. If we look at their Fagerstrom aspects, the Fagerstrom levels are actually lower risks than what they are for each one of the drugs. They had the low risk, mid risk, and high risk. If we actually take and look at the prevalence overall of their overall diseases, they actually had the classic cardiovascular comorbid diseases that you would see in primary care, in endocrinology, and even in cardiovascular clinics. Now, if you could see this, it was pretty much a no-brainer. Whether they were on the 3 different phases of the study, the risks or incidence of a major cardiovascular event happening, right, or a MACE was very low. In the 2,000 of each group, there was at most, as you could see, in the placebo group, okay, had 8, and bupropion had 9. In the end, it's very limited numbers, and it showed right away the actual safety of it. On top of it, and I apologize for this because it's not showing up the way it is, if we actually looked at the varenicline, if we looked at the actual risks themselves, it would actually, as you can see, as the graph is tracking all the way down, it actually showed definitely no higher risks for the actual patient. If we looked at their actual Fagerham cardiovascular risk scores, again, many of the people who had any type of MACE was still very, very low. The next few slides are going to continue to keep going over and over and show you overall if they even had any of those 6 factors. Again, we had lower and lower numbers of actual incidents, whether it was cardiovascular death, non-fatal MI, and as you can see in the top left corner, any of those actual aspects that happened, demonstrating more and more and more of the importance. And if we looked at, again, if we looked at the MACE plus people risk factors, the MACE factor pictures, actually, the risk factors were actually, again, as you can see, pretty much around the 0 mark and not much deviated away. Now, I'm going to continue and belittle everything else, showing, basically repeating from the Framingham cardiovascular risks. As you can see, still very, very limited numbers. These are individuals who were, and we included all 6 of the factors into it and actually demonstrating it. And then we continued to look at the occurrence of endpoints and broke it down for you in each one. Not just that, but with cardiovascular deaths, non-fatal, they broke down, as you can see, very single digits, even down to the point of like new onset or worsening cardiovascular, peripheral vascular disease. As you can see, in each group having 2,000, there were very, very limited number of people to do it. On top of it, what's interesting, what I find very interesting in all of this, there was not much, there was a little bit of a change actually in the actual heart rate diastolic, but there was a definitely, as you could see, bupropion scored the best out of all of these factors for weight. And the reason is because of the norepinephrine aspect in it, because it has dopamine stimulation, norep. And what it is actually one of the factors that we have to watch out for bupropion is individuals who have type of bulimias or anorexia. As you can see, the weight difference between the groups, although it shows a little, it still favors the bupropion itself. But truly, there was a small change in everything, but the individuals were really able to quit smoking. Now, if we look at this overall study, the reason why I put this slide up is why I wanted to show you is this 1 year multi-senior and not multinational, it's international aspect really demonstrates for us that you can use any of the first line agents that we showed you to actually help individuals quit. The coming trends that you will start seeing in the future, which I believe the NICE guidelines and the US guidelines are going to start updating, is the fact of having combination therapy. Combination therapy is going to become the newest trend, and it's to the comfort of the individual. On top of it, you will also be seeing more and more aspects of newer agents similar to cysteine and other products that will be coming in that will actually be changing the field of tobacco cessation. With that being said, this is the fundamental principle, brothers and sisters, I'm putting for you. Treating smoking is the exact same way you manage any chronic disease or risk factor. Please, this is one of those aspects that you need to focus on. And on top of it, please understand that most smokers don't plan to fail. They fail to plan. Give them the 60 seconds of your time, and trust me, you will definitely make huge changes in their life. Thank you so much.
Outstanding, Dr. Iyad. And let's have Sharif Bakir on.
Yes, I'm on.
Right, excellent. So now we're going to entertain comments and questions of our attendees. We reached 268 who are active with us now. There are a few questions. First one is it addiction or dependence? And this, Dr. Mohsen thinks is dependence. So Dr. Sharif, answer.
I think that because what is the definition of dependence and what the definition of addiction? This is terminology have been interacting with each other. Yani we don't want to confuse the definition. So addiction, there is when you addict to something that you have to repeat it to do it, and you are forced to do it. We'll put all this under the term of the habit. Habit will cover both addiction and dependence. But dependence, which means you are addict, you mean that you need this and you have to take it. And the dependence, that means that you are depending on this. Yani, so this is under the psychological terminology. We don't want to confuse the audience. My opinion, I will put it both under the habit. And the addiction, we can control it by the replacement. This is applied to I mean, anything, any addiction to anything, you need to do the replacement to stop the need for this. If Dr. Iyad want to add something.
No, I think you hit it on the nail. I mean, it's ultimately, it's a two-headed monster, as we usually will call it in English. It's something that you really have to actually evaluate. When patients come in, we spend a lot of time trying to understand. Some people are really physically addicted, and you got to deal with the addiction side first, then as much as possible. But I agree with Dr. Sharif. The dependence aspect, sometimes it's blown away because of all the, mashallah, medicines that we have now. We want to give them medicine. We treat it almost like any other thing. Just here's your insulin, here's your metformin, enjoy it. We really need to take a step back and balance it out, but we have to evaluate it. Because there are some people that'll tell you, they'll come in and they'll tell you, I smoke just 3 cigarettes a day. I want to quit. I've been doing it for a long time. And a lot of research shows that if you're under 5 cigarettes, it's psychological. So you spend a little bit more time breaking it down and trying to do it. On top of it, we also depend, I think Dr. Sharif had brought it up, we also evaluate them for the psychological aspects. As he said, many of these individuals self-medicate with nicotine to control their depression.
Also, I want to add something. I mean, don't forget, because of the time, I don't want to show. there is some fault of the habit, which means habit, cigarette with coffee, cigarette with the football match, cigarette if you are feeling unhappy or you are in, it is a habit to take the cigarette. This is also very important. And there is a relation between coffee and cigarette. Match, watching, to see a football match or something with the cigarette. And usually, automatically, your brain, when you see the coffee or the match, already your brain automatically sees the picture of the cigarette. So there is some, it is, habit is a psychological things that we want to break it with the smoker.
So, if you look at any literatures and the speakers, when they start, they talk about smoking, they mention this. So smoking is highly addictive, kills millions. This is what they say all the time. I think you're right. But how can we, if we say the word addictive or dependence, which one is more kind of, because what we want to do, we want to give the patient or the person having this problem some kind of power. How can we empower the patient? But which word make him more control?
Dr. Abdullah, I think when the patient come to see me in the smoking session clinic, the first word I told him smoking is a very pleasant thing. He will smile immediately because he don't want to expect me to tell him why you are a smoker. What is this? So this is what I am telling you. Smoking is a love story with the wrong partner. It is a love story with the wrong partner. The one who smoke, usually, for example, if you went to Canada, for example, sometimes the temperature is minus, sometimes reach minus 25. You imagine, and you find someone go out in the balcony to smoke and keep his children inside just to smoke, to speak to the cigarette. He loves the cigarette. So this is very important. So when you talk to it is both addiction and habit, and both of them. But addiction is the easiest things to be treated. The habit is the difficult thing to be treated.
Okay. Yeah. I would just want to take you back to history. If you look at people the prevalence used to be like 50, around 50 in the past, like 50 or 60 years ago. So what happened that resulted in reduction of the prevalence? At the high level, then we come to the individual. What happened, Dr. Sharif and Dr. Riyad? What happened? Why the prevalence of the smoking gone down?
Well, the sad thing is that I think there's a lot of effort in a lot of the countries that can afford to do it, okay, for trying to lower the prevalence of it. Sadly, the prevalence itself isn't going, it's steady right now. Remember, I always tell folks that the Philip Morris groups in the United States, after we were pushing the campaign of increasing the age to 18 to 21, and many of the government interventions and the actual discoveries of their methods of how they were actually pushing it to young kids and everything, what they finally realized is, well, in many of these places like the UK or here, we don't want to put all our business. So they went international. So they're in many of the countries now where there's no strong regulation. In countries where there's good regulation and good control, you do see it. In the US, the numbers are going down. On top of it, the idea of a cigarette has also evolved. As we've seen through the times, the cigarette imaging from Dr. Sharif's picture that he had of selling it, or the doctors endorse Camels, has changed. And people now see cigarettes as something that really I don't want my child getting into. And we started learning more and more and more of what the actual physical changes. And we're putting more campaigns. But sadly, in many of the Southeast Asian countries and many of the African countries, Philip Morris is putting out huge campaigns. And remember, we've taxed here, mashallah, in the UAE and in the GCC, we've taxed it. And many of these other countries, there's no tax on it. So you could say that there's been a lot of efforts to lower the preference, but only in those countries that can afford it. But I also, before I'll turn it over to Dr. Sharif, if he wants to add more, is also in those countries, those insurances have actually jumped in and have said, look, we'll treat you, we'll give it to you. With the new Affordable Care Act in the United States, now people can actually go to their primary care doctor and their doctor can spend more time with them about tobacco and feel I could get a small reimbursement for it. Because now, before, it was something that was just like, well, look, just try to quit if you can. Now it's, I need you to quit. Why? Because those are some of those 5 factors that insurances are reimbursing me on. If your blood pressure is in control, they lower my reimbursement. If your sugar's not in control, and now if you're a tobacco user and I don't try, they lower my reimbursement. We're motivating people to jump into the game more and try to lower and catch this. And lastly, and we're focusing more and more on these young kids. But sadly, now we have a new enemy or a new cousin to the cigarette, the e-cigarette, which again would take all night to discuss the actual role of it now and how the Philip Morris has taken over that game too and changed it and normalized actual tobacco smoking now.
I'm totally agree with them, but as I'm telling you, during my smoking session in the clinic, I usually sit with the patient 45 minutes. In the first half of when I'm talking to him, I have a program. I'm seeing him. I have a presentation in the video, and usually I talk to his mind. This is the most important.
Yeah, I'll come to that, Sharif. I'll come to that, and I'm just talking at the governmental level. The drop in prevalence, Dr. Iyad mentioned, is happening in the developed country. Unfortunately, it's not happening in the developing countries or the third so-called. So, I mean, if I go back to the history, 1947, 1980, there's a sharp drop in the prevalences. And that reason for that, as experts say, is increase in price. Money, make it expensive. People, the people are not able to afford. Khalas, the prevalence will goes down. So that's the thing at the government level. But then I'll come to you, Dr. Sharif, because you are expert, guys. You're dealing with a patient. You're not, you cannot change at the governmental level. So take us to your clinic, Dr. Sharif, and tell us, how you divide them, of course, to low risk and high risk. Low risk, of course, counseling, which is, tell us how you counsel your low risk and then high risk.
Actually, I'm not putting high risk or low risk, because be honest with you. Okay, what I am doing for them, when the patient came to my clinic, start to talk to him about the mechanism, which I show it to you. And then I told him I will stop now, and I start to talk about the heart in an indirect way. I try to show him how the heart is a magnificent machine. I told him your heart is pumping 4,000 times per hour, 100,000 per day, 36 million per year. So, and I start to talk to him about and show him some form of coronary artery normal. And then I told him, all of us, we have fatty deposition in our vessels. He started to listen to me. I told him, all of us, we have this fat, but suddenly this fatty deposition will rupture. And I'm showing him how it ruptured, how somebody was died suddenly, something like that. He started because I'm showing him videos in a nice way, of course. And all the time, the problem, don't try to deal with patient as a teacher and student. He will never listen to you. He's not coming to listen for a teacher to a student. You have to talk with your patient as a friend. This is a very important thing, to let him to listen to what you are saying. So this is the way I am dealing with them.
السيد ما ينفع يعني تكون حبيب معه. Doctor, there are questions about patients who are smoking, also depressed. So how can you start a patient, a medication which might make him to suicide, according to some of those people?
Yeah. No, listen. As I said, when they come to our clinic, we do a generalized screening with it. In the Middle East, as we know, that's a very sensitive topic, and we really respect, and we try to do our best without coming out. I have to admit, mashallah, with many of the patients who do come in, it's open dialogue and open discussion with them, really clearly. What we try to set up a goal with them. I think ultimately what we try to do is we try to debunk, of course, as I said in my type of slides, is the fact that many of the people are called what I call Googleologists. They Google everything, okay? And they see this, they see that, and they always feel that I heard this about this drug, I hear this drug. I always tell them it's not the only drug. We have multiple options. It's like I always tell them, again, what I have to do is in many respects, work with them and find out what is it that makes them tick and what makes them smoke. And if many of them tell me when I'm sad, when I'm depressed, or when I'm by myself, when I'm lonely, or stuff, or they'll associate it with a past event. You know, I quit for 5 years, and then after I got divorced, the questions start coming about is there any type of depression or any type of anxiety or any type of psychological issues that come about? I have to admit to you, alhamdulillah, I mean, with many of my patients that I've had, I haven't had that. I've had the mood changes. We can adjust the medications. And my suggestion to my colleagues is, before you stop, because it's always a knee-jerk type of thing, sometimes lowering the medication. I tell my friends, if you give an individual a calcium channel blocker and the blood pressure is drops very low, can you adjust the dose? Yeah, if we can't adjust it. Can you switch them to another thing, like a beta blocker or to an ACE inhibitor? Yes. So why can't you do the same with many of these medications? There's many first-line agents that are out there, but we always want to get a baseline of all your patients. You should get to know them, figure it out. We're also very blessed. We have a good psychology department. We also have many social workers where we're at the main campus that actually come in, and if we feel that there's any need, we send over for a quick evaluation.
Abdullah, I have 1 minute to say something. One of the things one of the trick which I'm telling to my patient, for example, you know, somebody tells me, doctor, I'm taking cigarettes since 20 years, 25 years, something like that. So one of my talk with him, I told him, do you have a friend with you since 20 years? And this friend, after I show him the heart, how the heart attack is happening, I told him, now you have a friend with you since 20 years. You speak to him every day, and you sit with him, love with him, everything. And then you start to let him to be visiting your family or something like that. And he started to listen. I told him, and then suddenly you discover that this friend start to cheat your daughter or your wife or something like that. What you will do? He said, what is this, doctor? I will never allow him to come back. And they start to be nervous. I told him, why you do this? He's your friend since 20 years. You love him. Yes. He said, but there is a red line. I mean, this is something I cannot accept. I told him, okay, the cigarette is a cheating friend, because the cigarette is not cheat with your daughter or your wife or something. It cheat with your life. And once you became ill, everybody will ignore you. And I'm showing them a story. So at the end of my session, there is some questionnaire. I give it to them, 6 questions, 1 by 1. And I let him to answer these questions. And I told him, read this question. Tell me what is your answer. And finally, when I feel that and the final question, he said, I will decide to stop. You get my point? And I am not forcing him to stop. And I told him, but believe me, you are my clinic, I am seeing you. If you go out of my clinic, I will delete your picture from my mind. If you want to continue smoke, it's up to you. It's not me. I am not the one who will be harmed. You are the one.
I'm sure you
try to be psychotherapy with him.
Excellent. I mean, this is the comprehensive of expert like you, Sharif and Iyad. I think, you know, approaching the patient from holistically, not just. So there are many questions from the attendees about the therapies. So maybe both of you, your input. Which one you start first, and when you add the second one, and just take us through that. So people want to get some experience from the experts.
If you want, I can tell you real quick. I mean, the best way to break it, we call it the Cleveland Clinic. I created, since we were #1 in heart and everything, as you know, with the ECG, we have PQRS. So we basically take our patients as a plan. We call it P, which is the plan. We sit down, it's a consult. We sit down with every patient. We give them a basic plan. And that's where, like Dr. Sharif, we give them a questionnaire, we break it down, and we find out, again, what is it that's actually the main trigger for them. And here, it's work, worries, their families, their stuff. We try to get down and deep into it. We then review their past quit efforts, and we try to make sure that we understand them, again, as you said, Dr. Abdullah, holistically. We then we try to bring them back on their quit date so that they understand where they're at. We hope that they are quit. If they're not quit, we set a new quit date with them. Then we bring them back usually a few weeks later on a relapse. We call it the R, the relapse discussion. And then we bring them back a few weeks later on a sustainability visit, so PQRS. And in each one, we try to interact. With today's technology, you're able to really interact more and more with the patients. Phone calls, things to that extent. We try to really also minimize the interactions on social media due to the privacy of the patient. However, we're finding out, listen, I'm gonna tell you something very amazing about the UAE in clinic, okay? My average age of my patients in the United States was 55. Here, the average age of wanting to quit is 32 in our clinic. That means we have a very, very, very motivated population in the UAE, a very motivated population that I think we need to capitalize on. And sadly, what is the difference between treating the 50-year-old to the 30-year-old? Well, the 50-year-olds, your baby boomers, that generation. Now we have millennials that are coming in. Millennial thought process is a little bit different. So we have now started to actually approach them from a generational approach too. How do you approach the older generation to the newer generation? The newer generation is more on what's the technology, what's the evidence. The other one was just suck it up and I'll quit. So that's kind of our 4-step method with intervention in between. But that's how we basically would be a clinical session or an actual drive through the process.
To summarize, just very quick, I'm usually started by the replacement therapy. And then if we are not able to, I'm telling him just simple question. Why to hit, cockroach by pump? Hit him just by just very simple thing. If you are not able to hit him, okay, will go after. So usually I start by replacement therapy, and based on the response of the patient, will continue.
Sharif, maybe about the nicotine therapy, what type? I mean, was it patch? Is it spray? Which one you are?
Usually we are using the patch, and also the size. I mean, the size or the milligram of the patch depend on how many cigarettes he's taking. But as Dr. Ed said, some of them came to me. They said from the beginning he didn't want to listen to the patch. He said directly he want to go to the tablets. So it is individualized. I cannot tell you. From the first moment when I sit with the patient, I start to have an idea about how I will go in this direction. Some of them, I have one patient, this is a true story. He's taking 60 cigarettes per day in the last 30 years. 60 cigarettes. And when we do for him the smokulizer, he was carbon monoxide was around 80, some number which heroic. And after the discussion for 45 minutes with this patient, 45 minutes, and when we saw him after 1 week, the smokulizer returned to normal and they stopped without taking anything.
So Sharif, so you start the nicotine therapy. When do you expect your normal to stop the smoking?
Well, usually when I start nicotine therapy, I am expecting that he will start on the same day at night. He will take the nap. No, really.
No, to stop.
Yeah.
To stop. Okay.
Yeah, because I explained to him, I told him very simply, sometimes not the scientific truth, but I told him, now for the addiction, I give you the nicotine patch. I filled your brain. How many cigarettes you smoke? He said 20. I told him, okay, I am giving your brain now 40 cigarettes. He said, what, okay. I'm coming to stop. I told him, yes, I give you 40 cigarettes through the skin. In the morning, when you awake, your brain is already contained 40 cigarettes. Why you smoke? You will not smoke, but you will go to your hand will go to the cigarette by habit. Don't allow the cigarette to be beside you. The same like your brother. Don't let him to look to the lady.
Okay. So the patient got side effects from this nicotine. What are you gonna do?
Some of them, the side effects, the only side effects where I saw in the last few years is itching. Some of them, they develop itching, and this were very minority.
Yeah.
And we replaced usually, because nicotine I need it for short time. I'm not needing nicotine patch for a long time.
Right.
If the patient start to be continuing for a long time, you have to change your strategy immediately.
And I just want to add to Dr. Sharif, look, Dr. Abdallah, when you're trying to sell medications, it's similar to trying to sell your insulin levels. or a diabetic. Here, let's give you an example. I usually try to present it to them. I say, if you're a diabetic and I'm going to put you on insulin to lower your sugar levels, but you continue to eat sugar products, what's the benefit of my medication? Nothing. Same thing with this type of medication. If we do not try to push for a quit effort on the patch, on the Champax, on the Varenicline, on the bupropion at all, then there's no benefit to it. You're smoking my drug out. With each one with their side effects, as I said, you can adjust the medication, you can adjust the dose, and you can switch them to others. I think, you know, I always tell people, you shouldn't just give somebody and say, go to the pharmacy and start on aspirin. Aspirin does have its side effects. So you should take this, because what many of the issues when we had many of these medications, especially the pills that first came out, many of the physicians were just handing them like candy. And this is called Varenicline. It's going to help you quick. Just call me if you need me. No one was monitoring it because, again, tobacco wasn't that important aspect in their overall practice.
So because, you know, when you come to therapy of Varenicline, it says, you know, in a week to 2 weeks, you expect the patient to stop, you know, smoking. So, but in your practice, you expect them from day one, is it? When you start Varenicline, for example?
No, for my aspect, again, for Varenicline, it depends on the actual patient that comes in. I have had patients that say, I'm here to see you, I'm quitting today, we start. The majority of them are, I try to make a decent compromise in between. So we try to set a quit date within 14 to 30 days of the quit. We try to educate them. We create a diary where we try to follow with them. And our 1 week follow-up phone call with them, we ask them. And I always tell them, I say, listen, this is something that's very important to me. Just tell me the truth. If you're as it is, you've been smoking 20 years, 30 years, 5 years. I can't change it sometimes in a day. I'm going to try. But in the end, what I'm asking you kindly to do is to try to put in with the effort with me. It's a two-way. I can treat you with medication that, as it's been said, to make your brain think you've smoked. But I can't change the other aspects of your friends, your family, and your folks. Okay? So you need to actually do it. If there's something that we really focus on here in the Middle East, is we want to drive them to actually benefit themselves. And in many respects, remember the 3 Fs. In Middle Eastern customs, we focus on faith, family, and friends. They are the 3 Fs that drive us. So we try to build a social network that relates many of those aspects into their practice on top of the medication. And we really drive them to make lifestyle changes. Again, it just takes that one keystone change in their life that can domino. If you could quit smoking, then maybe we could get your weight down. Then maybe we could get your sugar down. Then maybe we could do this, this, and this. And so we try to give them strong, like emotional and motivational types of speeches while they're there so that they can believe in the medication, but also come back to us if they're having issues with it too.
Yeah, so because we have lots of family medicine doctors with us as well, they're asking, you know, you guys expert, just simplify it. 5 A's or 3 A's, which one are you using in your counsel, you know, for counseling your 5 A's,
in family practice, we always try to push the 5 A's. We're blessed, we call it 3 A's and an R: ask, advise, and assess and refer. So of course, Dr. Sharif and I are blessed. We have actual organizations that support having centers like this. So we call it 3 A's and an R. So the R is, of course, refer. In primary care, you really should focus on it, especially if you're owning it. I think the UAE, especially Abu Dhabi, we have 13 tobacco treatment clinics throughout all of the Emirate itself. So family practice folks should try to consider asking, advising, assessing their quit and referring if they can.
And the success, Sharif, for your therapies. I know you're excellent. Just forget about counseling. I know maybe your counseling is do the most of the job, but forget about counseling. Just focusing on the therapy itself. Nicotine, Varenicline, what's the success rate in your practice?
To be honest with you, theoretically, they said Varenicline is because it's being tested. But for me, as I'm telling you, maybe I'm a little bit different, but I'm starting with the nicotine. I'm insisting on the nicotine. So it will be, for me, the nicotine is compared 5 and the varenicline maybe 1. Yeah, you get my point. Maybe most of the other people they are the reverse or 1-to-1 or 2-to-1 or whatever. But I am because the varenicline, if you started, the patient will need it. He will be on 3 months at least, and some of them they stop after 1 week and then they return back, and so I am.
The reason, Sharif, the reason why they stop the varenicline after 1 week, what's the reason?
Some of them, they said, okay, once he stops smoking, he stopped the varenicline, and then he will find himself return back. Because the idea is, now, varenicline or whatever, the idea is what? The idea, I want you to be away from the cigarette for more than 48 hours, which is the addiction have been finished, and then to give the time for the habit to be controlled. So the longer you are away from the cigarette, the longer the habit will be controlled. You understand? And if somebody say come back after 6 months or 1 year, smoke again because he feels some psychological depression, any catastrophe in his life, or something, he will start to smoke again because he thought that this is the way. The same like addiction for alcohol. What you are doing for alcohol, the same story. He stopped the alcohol, and then after 5 months, 7 months, you find that he still returned back once he faced any psychological or any emotional trauma.
Yeah, but your success rate of nicotine is what's the rate?
To be honest, I have done statistics. I find that I reach, maybe I'm not exaggerating, but I reach up to 65 to 70% with my people. It's a very high incidence. Maybe Dr. Ed have the same. Usually, if you look to any statistics, anything, talk about 35 to 40%.
Oh,
but
right.
Yeah, I mean,
Dr. Riyad, your success rate of nicotine. Then we come to varenicline.
Well, no. I mean, my success rates in general with any type of quit efforts, the international basic baseline for anybody is I would like to let the crowd to know that you should always remember, if you could get 1 out of every 5, 20%, if you could get 1 out of every 5 of your people to quit, you're a champion. And do not let that and be told otherwise. Dr. Sharif, mashallah, is an expert. He's done it for years. He has his techniques, and it's similar to any.
I'm saying he got a secret of the counseling, as he's excellent.
Exactly.
It's not just therapy, because really, mashallah, I just want to say therapy itself. In your practice, what's been the success rate? So you think around 20%?
No, ours is usually between here in the UAE we're about 30%. In the States, I think we were at 42%. But I really want the audience to put that number, especially if you're in family practice. Remember, you don't have the resources sometimes in a time like we do. 20% is the magic number. If you could get 1 out of every 5 of your patients or smokers come in to quit, you're doing good. Right. And I just want to put one last quote for it so we could get to the next question is, it isn't the drug that makes the man, it's the man that makes the drug. So as it is, we really, we pick and choose the drugs that in our practice, we pick and choose the drugs that it is, but we tell them, this is like, if you had sprained your foot, we use a crutch to get you better until your foot gets stronger. Once we have full control on the psychological aspects, we start tapering off these drugs. And the same thing with anything else is I try to tell them, it's only for a short time, we can do this, but I need you to invest. So we set a expectation with these individuals of what the treatment plan will be.
So, Dr. Sharif, in our CCU, we have almost like 70 or 80% of our patients are smokers who are having acute coronary syndrome, especially here. And do you think the right time there, when we do a CCU round, to disclose this and to speak about it?
Of course, what do you think? Usually, because this is the weakest time for the patient, this is the weakest time in his life. And you have to, but as I told you, the problem is don't take it in the way of teacher and student. This is very important because I want his brain to listen to me. You understand the point? So you have to, and each individual have a different way to tackle him. The same, I will tell you something, Abdullah, to understand what I'm saying. If your son want to marry a lady and you don't like it, how you can convince your son not to marry this lady? What is the way? What is your attitude? What is your attitude? You have to tailor it depending on everybody, because the cigarette is a love story. Believe me, And you have to try to find each individual is different.
Find a bit a nicer.
Yeah, because if you told him don't do that, for sure he will do it.
Nicer alternative. Alternative should be nicer.
Yeah, you have to understand how his mentality, what is his weakness, what is his power, how to attack this individual.
So people.
I just want to add to this.
Okay.
I was just going to ask to the CCU, or when you have a patient on the inpatient side, I just want to put one thing. I know we have probably a lot of physicians on board, but we probably also have the nurses, and the pharmacists and everybody. The research does demonstrate individuals are more motivated to quit when they have multiple people, not just the physician, talking to them. So if you do have a chance where you can't build a center, but you can build an actual process, I think don't forget to leverage the pharmacists, the nurses, your educators. I would like to tell you a side story. At the main campus, again, at the main campus, when you're coming in for surgery, you know who screens the person? It's the actual receptionist at the front desk. They would go, Mr. Abdullah, do you smoke? And then you say, yes, I do. You know you can't smoke in our facility. Will you need help while you're here? Yes. It is the actual receptionist that initiates the actual consult for the tobacco cessation specialist. And also, I don't want to put it out there, and your respiratory therapist, another great group you can leverage on the inpatient side.
Yeah, I think the comment from some of the participants that Dr. Sharif is living a great love story, but maybe in a I don't know.
Yeah.
Doctor, okay, let's go back to the you are in UAE and we have people midwah, shisha, all this. Where we put this in terms of cigarettes? What is it?
Oof. Midwah is a dangerous agent because it's basically the tobacco. I always call it the tobacco crack pipe because it's one big hit in it. I mean, we're still trying to evaluate to see what the equivalency is. We've got numbers that we've been told that it's much stronger than an actual cigarette and hit. Why you get the docha from it. We in this past year, not last year, but in 2018, a colleague and I, we actually put an abstract into the European Respiratory Society, and we showed them that treat midwah as if you're treating a cigarette. Do not look at it in any way. We had great success of using medications that are frontline for cigarettes and helping to treat midwah. It's just the question is the equivalence. Dr. Sharif already alluded to a point. You really should try to calculate the amount or the true dependence of it, of how much your nicotine patch or where they are. For example, what he's alluding to is if they smoke 40 cigarettes a day, you should give them 2 patches. It's called the Mayo model or the high dose nicotine patch model. And what you do is you give them 42 milligrams or 221 milligram patches. Some people aren't comfortable with that. It's usually us and the experts. The question is with someone that high, say someone takes in, a magic number we've heard is 3 to 5 cigarettes is equivalent to 1 puff of midwah. So if you take the numbers, if someone takes 10 puffs a day, that's equivalent to 30 to 50 cigarettes a day. So if we were to do patches, we treat them with 2 patches on there, or we switch them to varenicline as an option to treat. It needs better control. It needs a lot of control. I think we've let it go too long, and I know the government has taken strong strides, but if there's one thing we really do need to control, because I'm going to make you laugh, they opened up a midwah shop in Cleveland, Ohio this past year, just to make you laugh of how much this has become another pandemic out there in the world. So if Cleveland has it, then we know the world has to have it. I have to put that out there. So,
Dr. Sharif, shisha, midwah.
Many times I'm using 2 patches with the patient. And as I'm telling you, let us to put the headline, smoking, whatever, midwah, shisha, or cigarette. This is the headline. And then all of them are the same reason why you smoke. And if somebody smoke, why you smoke? Whatever the type of smoking, but why you are smoking from the beginning. You get the point? And why you continue to smoke. So psychological aspect is very, very, very important in this. And you have to tackle this with the patient. Whatever, as Dr. Ed said, whatever medication you are giving, if he's not willing, if he's not accepting the idea, if you are not solving his problem by the mind talk, he will never stop.
Yeah, we have some.
But I was going to say, just to add, because I think this may be something you may be leading to. And the other problem is the next epidemic, which is vaping. Vaping has a lot of psychological aspects. I mean, we also want to put in shisha or argile. That's another psychological. I don't smoke. I only smoke 1 day a week. I mean, smoking's psychological aspect, because vaping, and I want to put a quote, vaping is smoking is vaping. It's all the same. It's the new Diet Coke. Sure, you could go to McDonald's and you can get the low calorie or the Diet Pepsi with the Big Mac meal, right? But in the end, you have to actually understand that they're changing it nowadays, the tobacco industry, and they're making it seem like that it's a lot of healthier options, different options. It isn't the same old cigarette. The other thing too, which now has opened up, is IQOS. I'm smoking a smaller cigarette, or I'm not burning it. They're coming up with newer ways to psychologically normalize it or to make society accept it again. And it's becoming harder and harder from our side on the tobacco arena to fight these. That's why you really need strong policies and control by governments and other agencies to really control this, because it's going to get out of hand, because the tobacco industry bought out the e-cigarette companies. They own them. You may not see it out there on paper, but they own them. And if we don't fight against this animal that they're going to do, it's going to be, and the next generation is going to be addicted to something that they think is just cool water with nicotine in it. And that's the sad part about it. It's becoming very, very, very psychological.
Yeah, so we have of course experts with us here as well, attending the meetings, and they are saying we've tried counseling, we've tried therapies, sad stories, the patient not stopping. So now with the e-cigarette is available, and the study shows that more people using e-cigarette to stop smoking than using the therapies. Dr. Sharif, you're saying that when you don't want your son to marry a person doesn't like, so this is alternative. What about e-cigarette?
I tell you something, to be honest with you. For me, some people, I find that the ideal for them after a long discussion, when we find that we reach the end, I will allow them finally to stick the e-cigarette, because also they have to differentiate between the e-cigarette, between the vape, between the IQOS. So there are so different things. We have to differentiate between heating and between burning. And also you have not to forget the psychological story. So the people, but the only problem is the young population. Young population will not allow them at all, because the problem in young population, they start from day one native vaping. You get the point? He was not a smoker. He was not somebody smoke and they're not able to stop. The young population, they go direct to the e-cigarette or direct to this because they have the impression that it is not harmful. This is the big problem, because we don't know in the long run what will be the effect. So we have two types of people: people who are a smoker and are not able to quit, and the people who never smoke but they start jump immediately to the e-cigarette. This is two different communities.
So it is effective in helping stopping
for certain people, and it is beneficial for certain individuals. Somebody is taking 60 cigarettes per day, develop heart attack, and he is not able, whatever you have done with him, what you are going to do? Are you going to tell him okay, bye-bye, continue to eat 60 cigarettes? I don't think so. I think this type of population, they maybe help, it would be helpful for them to take the e-cigarette.
So you make sure that, so you make sure, both of you experts here, you make sure if خلاص يعني patient going for e-cigarette, they have to stop the traditional smoking, صح?
Of course.
Yeah, I mean,
you
can't do both. I mean, listen, a lot of the patients who do come in, especially the younger ones, are doing both. I will say this, though, about the e-cigarette. I think Dr. Sharif is correct. There's a lot of the problems that we're seeing with it. We're going to need generations probably to figure it out. Think of how long people used to smoke cigarettes before we figured it out. With that being said, it is true. If I have a patient who's 65 years old, used to smoke 3 packs a day, and he jumps to vaping, is it less harm? By theoretical aspects, yes, you can put it that way. But now I have a 21-year-old who jumps in, and of course we know it's younger, and he's been smoking it. The one trick I would say to the audience, if you really want to open their eyes, is don't tell me how many times a day you smoke it, because that could be any time. How many puffs do you take? Okay, how many puffs do you take on your cigarette? I almost treat, in many respects, if you ask them how many puffs and they start counting it, they kind of freak out. And that's how they kind of taper down with the e-cigarettes or vapes, if they want to call it. I mean, we've treated it with it. Many people who are really addicted, we've treated them with medications and it does help, but it's too psychological. It's like shisha. I mean, how do you tell them just take the nicotine patch one right before you go out with your friends on the weekend? We don't know. We're still figuring things out and what we're trying to do to help these individuals. I think we need more research. I think people have learned a lot, and God forgive me, what we warned them about happened. There were finally deaths from e-cigarettes, and popcorn lungs scared everybody. But I think in the ultimate run, it's gonna need us to focus on the very young generation, okay, under the age of 10, and really try to change it and educate them to see what it is. That's the only way. If you told me right now, what is our best chance, is to catch that young generation and try to get them. Because again, with good regulation and good education, I think we can make a dent into the e-cigarette.
Okay, we're almost reaching our end. So I was just gonna say, both of you, maybe in 1 minute, then we come to your final thoughts to the audience. Why in Ramadan, people who are so addictive to the smoking, they able to stop at that time? What's it? What's the secret behind that?
Faith.
So you're building on that, Sharif.
Yeah, I am.
I'm all the time using this example, Abdullah, with my talk with the patient. And some of them, they said, doctor, I am from morning till the iftar. Once the iftar came, I didn't eat anything. I jumped to take all the cigarette. You understand the point? So it is a relationship. The cigarette and the person, it is a relationship. Part of it is addiction, part of it habit, part of it's psychological. I mean, it is a complex story, and each individual, you have to deal with him separately.
I agree, completely agree.
So in 30 seconds, each of you give us your thoughts about what you want, the message to the people who are listening to us, whether they're practitioners, patients, whoever, please.
Dr. Sharif, you go first, my friend.
I am telling them, if you are failed this time, you will not fail. Try with your patient 100 times. Every time you have to try. If you're able to succeed to let him stop, well and good. If not, try again and again and again. And you have to raise this with your patient, as I'm saying, not as a teacher and a student, as a friend.
Sadly, he takes a lot of, he did very good in summarizing it. I will say to my colleagues out there, several aspects. One, attempt in any way that you can. As I said, give yourselves 60 seconds if you have a smoker. Identify them and try to do whatever you can. I will also ask you, as much as it is, treat it like a chronic disease that it is. Do not treat it as anything else. Every chronic disease has a behavioral aspect and has medications that you can use. Consider to do it. And also, as I gave you that quote, these individuals don't come to you thinking, "Khalas, I'm going to fail." Most smokers don't plan to fail. They fail to plan. Sit down, create the plan, and expect, if you could get 1 out of every 5 of your people to quit, you are a champion in my heart. Remember that, 20%. Antibiotics, we could tell you 100%. But if you could get 1 out of every 5 people to quit, look at yourself as a champion.
I'm sure the attendees who are still active with us, 242, after an hour and a half, been listening to both of experts here. I think they enjoy the theory and they enjoy the practical points from both of you. I think the journey is, started, and I think we are all, together fighting this second, I think, major risk factors for, for cardiovascular diseases. I'd like to thank both of you for your great input. I'd like to thank Pfizer for making this event possible with the Emirates Cardiac Society. And please, the attendees, do the survey and you get your certificate. I think CME hours from DHA. Thank you very much and stay healthy. Assalamu alaikum.
Alaikum salam. Salam.
Bye.